My name is Lane Trinkle. This is my SP reflection for the knee evaluation. Overall, I think I did a really good job building a patient-clinician bond. Whenever I was palpating, I told the patient if I hit a tender spot or anything painful or you feel uncomfortable, let me know. I can stop. I palpated the MCL, pes anserine, both hamstring tendons, the patellar tendon, the patella, palpated all around. Joint line, there was joint line tenderness, but most of the pain seemed to come from the MCL. I didn't test for ACLs during the special tests, which I kind of beat myself up about as soon as I left the room, because I realized that I had tested for MCL and meniscus pathology and pain, so I tested for both those and left out the ACL, so I couldn't rule in unhappy triad. But overall, I don't think that hurt my evaluation for the simple fact that the treatment plan is going to be the same, whether it's just meniscus and MCL or if it's the unhappy triad. We're still going to get the patient into a crutch fitting or not weight bearing situation, get them out for an MRI, have them come back with the results, and build a rehabilitation plan. The patient was really apprehensive throughout all the special tests, all of the range of motions and all the manual muscle tests. So it kind of flustered me as to what I should do, because throughout the history I felt like I'd built a good patient-clinician bond. She trusted me not to put her through more pain, and I didn't want to ruin that bond and put the patient through a whole bunch of pain whenever throughout my history I had already figured out, the treatment plan is going to pretty much be the same. It's a knee injury. I think I did really good with providing patient-centered care, because I was able to ask her, how's everything? How's walking upstairs? How's walking downstairs? How's getting to class? How are you doing since this injury's happened? Have you had to miss anything? I asked about, previous injuries, and I think all of that guided me to a really stable, systematic evaluation. I didn't have the patient, the patient didn't have to stand up except for walking from the chair to the table. I asked the patient, do you think you can stand on one leg? So we didn't do Thessaly's because she said no. So the Thessaly's was inconclusive. McMurray's was positive. And I was really surprised that she kind of knew where she would actually feel pain at. But in future SPs, I would like to have some sort of cueing or hint that a special test is positive when testing for it, just for the sake of the patient's not going to actually experience pain during these, and if they don't truly know what the special test is trying to test for, or when they're supposed to experience pain during special tests, we could get a lot of different things just from one special test. So I think we need some sort of cueing as to what special tests are positive. I think the patient did a really good job of kind of acting. She memorized everything. She memorized her lines. But she was very, very, very apprehensive, and in my head, I just didn't want to put the patient through more pain. I think my plan and treatment were great, because I didn't give the patient a timeline. She asked me if she was going to be able to go to her formal, and I was able to tell her, we can't promise that. Until we get the MRI results back, we aren't going to know if the MCL is grade 1, grade 2, or completely torn. And then with that MRI too, it would also show up if there was meniscal and ACL involvement, because I tried to test for meniscus, but all my tests were inconclusive, except for McMurray's. So I didn't really want to rule in just on one special test being positive. So I did tell the patient, there's probably an MCL sprain. I think I did a good job at not diagnosing the patient, but telling her what I thought was going on. And, we'll see what happens when the MRI results come back. I think I also did a really good job explaining to the patient the anatomy and putting it into not really layman's terms, but kind of showing her, what happens when an MCL sprain happens, because she was wondering why she got hit on the outside of her knee, but the inside of the knee hurt. And I think I did a good job explaining to her with a piece of paper why when the femur goes one way and the tibia and fibula go the same way, that puts the MCL on stretch and gives it a possible tear. Overall, I think I've come a long way from my first SB. I think I've shown that I can evaluate a lower extremity, but on the same lines, I've got a lot of things to work on. I missed out on the ACL involvement. I missed out on actually letting the patient know that there's probably meniscal involvement, and I didn't test for ACL. But I think with my palpations were, for the first time, I can honestly say they were meaningful and actually gave me hints and clues as to where to go with my evaluation. I think I did a really good job of having a systematic evaluation. I didn't have the patient turn over 8 times for the first time. I didn't have to have the patient stand up, sit down, stand up, sit down. I didn't put the patient through, more pain. I didn't exacerbate symptoms, and I think that, I built a great clinician-patient bond. So she trusted me, which is, in my opinion, probably the most important part of being a good clinician. Because if your patients don't trust you, then they're not going to come to you. If your patients think that you're going to put them through more pain, they're going to be weary of coming to you when they start to feel something. So I think I've done a really good job providing patient-centered care and having a systematic review. And like I said, I've got a long way to go, but I've got 2 more years and a lot more SPs to do. Thank you.